Okay, so without any further ado, we'll just move right to the next slide. So at the Alzheimer's Association, our work is about people and science. And we are a worldwide voluntary health organization dedicated to Alzheimer's care, support, and research. Our mission is to lead the way to end Alzheimer's and all other dementia by accelerating global research, driving risk reduction and early detection, and maximizing quality care and support. This evening, we're going to talk about the landscape of Alzheimer's and dementia science. We'll talk about some highlights in early detection and diagnosis, and then some of the latest advances in clinical trials, treatments, and lifestyle interventions. And we will also be talking about how you can get involved and some takeaways you can have from today. I know that this particular audience, a lot of times I talk to lay audiences, but I recognize that this is a clinical audience I'm speaking with. So forgive me if this is review to you, but dementia is a syndrome. So a syndrome is a collection of symptoms, and in dementia, these symptoms are related to cognitive decline. They can include behavioral and psychological symptoms as well as cognitive symptoms. And the important thing with dementia is that they are due to biological changes in the brain. Alzheimer's disease makes up about 70% of all forms of dementia. Many dementia people living with dementia have a mixed dementia, that is more than one pathology prevalent. Some causes of cognitive decline are reversible, and if it is a reversible cognitive decline, it is not dementia. So just to be setting our baseline here. Every year in April, the Alzheimer's Association releases our facts and figures. In 2022, we released facts and figures, and each year we have a area of special interest. This year was on mild cognitive impairment, and you can see in the upper right that more than 80% of Americans know little or are not familiar with mild cognitive impairment. And I'll talk more about that, but that can be an early stage of Alzheimer's disease. In general, there are more than 6 million Americans living with Alzheimer's disease, including 130,000 in Massachusetts. 1 in 3 seniors will die with Alzheimer's or another dementia, and over 11 million Americans are providing unpaid care as family and loved ones for people living with Alzheimer's disease or other dementias. In 2022, Alzheimer's will cost the nation $321 billion with a B dollars. And if we don't come up with a disease-modifying treatment by then, in 2050, those costs could rise to nearly $1 trillion with a T dollars. Alzheimer's disease is a continuum. And I just talked about mild cognitive impairment. In this period of time, we've got either asymptomatic mild cognitive impairment and then moving into dementia. In asymptomatic, there are no cognitive symptoms, but there might be biological changes in the brain. And that's why we're working very hard to identify a biomarker, which I'll be talking about a little bit later. Mild cognitive impairment indicates an early stage of cognitive ability loss. And then once the disease progresses to the point where it's interfering with daily activities, we move through the stages of Alzheimer's disease, which are mild and moderate, and then finally severe symptoms. The severe symptoms interfere with most daily activities. And just a reminder, if you have questions, just hit the Q&A button and pop them in there, and I'll be happy to answer your questions at the end. So the hallmarks of Alzheimer's disease, looking at it from a pathological standpoint, include 2 proteins. One protein is called beta amyloid, and the beta amyloid works outside of the cell. Beta amyloid is a sticky protein, and it sticks together and forms clumps that cause what we call plaques. The plaques go in between the neurons and affect the ability of the neuron to talk to the next neuron in line. There's also another protein called hyperphosphorylated tau, and tau is actually intracellular. It goes into the actual neuron, and it starts to affect the actual architecture of the neuron, of the nerve cell itself, and causes it to collapse and form what we call tangles. So you'll hear about plaques and tangles, and that's what we're talking about. An adult healthy brain, a healthy adult brain weighs about 3 pounds. And you can see on the far right here of the sagittal section of the brain, advanced Alzheimer's disease after the death of the neurons. An adult brain with Alzheimer's disease will weigh about 1 pound. So you quite literally lose about 1/3 of your neurons, of your actual cells that make up the brain. So what might impact your risk of Alzheimer's disease or dementia? We have our non-modifiable risk factors, and those include age, genetics, race and ethnicity, and sex or gender. Those we can't do anything about. We're born with them. The good news is that there's a host of modifiable risk factors that have an impact on whether we will get Alzheimer's disease, when we would get Alzheimer's disease, and how severe the effects might be. And those include substance use, education, traumatic brain injury, physical activity, cardiovascular health, sleep. The amount of sleep right now that is ideal for brain health is thought to be between 7 to 9 hours of sleep per night. A healthy diet, and we'll talk a little bit more about that later, cognitive and social engagement, and environmental and lifestyle factors. So all those things taken together are the cause of your overall risk, right? And what we need to do is study the risk from all angles to make sure that we're definitely addressing the issues. One of the things we like to say at the Alzheimer's Association is what's good for you above or below the neck is good for you above the neck. So those are things like your cardiovascular health and your physical activity, a healthy diet, and those things are definitely will have a great impact on your brain health. So there are gender, racial, and ethnic disparities in Alzheimer's prevalence and in clinical trials. Almost 2/3 of Americans with Alzheimer's disease are women. And initially, this was thought to be simply because women live longer than men. We know that, right? However, that doesn't explain this great disparity. And a lot of the research now is going into the physiology of women. And for example, is having a child neuroprotective? Is at what time you go into menopause, is that neuroprotective or somehow indicative of brain health, needing hormone replacement therapy or not using hormone replacement therapy? There's a lot of research going on into why are 2/3 of Americans with Alzheimer's women. Very similar to what we saw with the COVID-19 pandemic, older Blacks and Hispanic Americans are significantly more likely than older white Americans to have Alzheimer's or other dementias. In fact, Black Americans are twice as likely and Hispanic Americans are 1.5 times as likely. And again, there is significant research in looking at why. What are those factors that cause this disproportion? Part of it, of course, is that ethno-racial groups have been historically underrepresented in clinical studies, and this underscores the need for more diversity in dementia research. And we are, the Alzheimer's Association, I'm proud to say, we're on the front lines of really recruiting representatives from underrepresented groups in clinical studies. This is a really exciting time in research, and this gets me up in the morning. I'm also really proud always to say every year in September when we have our walks to end Alzheimer's, I ask my friends and family once again another year to please donate some more money to the Alzheimer's Association. And I tell them that the reason is that we have $300 million currently active in grants, in research grants, in 920 projects in 45 countries over 6 continents. And that's really impressive. We advocate. We have been able to increase the amount of money that the federal government through the National Institutes of Health and National Institutes of Aging spend. So in 2022, we will have more than $3.4 billion invested in Alzheimer's and related dementia research from the federal government. So here in Massachusetts, again, we are so lucky, so fortunate to have so many amazing clinical and academic research institutions in our state. In total, in Massachusetts, there have been 250 research awards between 1993 and 2022. We have 68 awards that are active. And actually, this number is wrong, 19.8 million. It's actually over $20 million now in active research grants. Our International Society for Alzheimer's Association Research and Treatment, there are 254 members from Massachusetts, 273 grant reviewers, and we have funded Massachusetts General Hospital, Brigham and Women's Hospital, Beth Israel Deaconess Medical Center, Boston Medical Center, University of Massachusetts Medical School, MIT, the Broad Institute, and others are our funded institutions. Early detection and diagnosis is critical to getting rid of the scourge of Alzheimer's disease and detection. And early diagnosis will improve emotional, social, and medical outcomes. It will help the person living with dementia and their care partners to understand the symptoms, explore treatment options, improve health outcomes, prevent complications, very importantly, to make legal and financial decisions, as well as accessing care services. It gives people the opportunity to participate in clinical trials and then to help effectively manage the cost of care. Biomarkers. This is, again, where I get really excited because biomarkers are totally changing the game. This is a PET scan. I'm going to talk about that in a minute. These are red blood cells. We are getting very close to having a blood-based biomarker, so that just how when you go for your annual physical exam, you get your cholesterol checked, we might sometime soon be able to look at things like, is there amyloid or is there tau buildup? In Canada right now, there's a study going on looking at eye health and the relationship between eye health and dementia. I believe it's pupillary reaction time, but don't quote me on that. And then, of course, this is your double helix DNA. There's always genetic research going on. So we're really trying to modernize the diagnosis because we know that 20 years or more before the symptoms appear, the brain changes of Alzheimer's disease may begin. So we really want to modernize this diagnosis so that we know, and then can we go back and change some of those modifiable risk factors that I talked about at the beginning. If we know that there's a predisposition, for example, to beta amyloid or hyperphosphorylated tau, can we do something with diet, exercise, cardiovascular to really have an impact on this? So here we go. Here's my total absolute favorite slide. what is a brain PET scan? So positron emission tomography is a scan that now can definitively diagnose Alzheimer's disease. So this is now the gold standard of diagnosing Alzheimer's disease. Back in around 2015, a researcher at the University of Pittsburgh Medical Center, who was funded by the Alzheimer's Association, Dr. Funk, found a radioisotope that would bind with the beta amyloid and on a PET scan would light up red in the brain, showing the presence of beta amyloid in the brain and specifically where the brain was. Nancy pointed out that I lost my mom to frontotemporal lobe dementia. Had this been available to my mom, we would have seen a lot of red in the frontal and temporal lobes, right? This is not the frontal or temporal lobes, but this way we can diagnose and also help to identify what type of dementia we're looking at. So this is just, they are FDA approved. Right now, CMS does not cover this unless you're engaged in a clinical trial, but we are working to get that changed so that Medicare will cover a PET scan if Alzheimer's disease is suspected. And the big deal here is from the IDEAS study, the imaging dementia evidence for amyloid scanning have they helped with memory care? So this study looked at 18,500 Medicare beneficiaries. The hypothesis is that amyloid PET results will lead to significant changes in patient management and that this will translate into improved medical outcomes. So how have we done? So in patients with a positive amyloid scan, the rate of Alzheimer's diagnosis increased from 80% to 95.5%. To me, that is a big win. But an even larger effect was seen in patients with a negative amyloid scan. So as the rate of Alzheimer's diagnosis decreased from 71% pre-PET, so that is 71% of people were told they had Alzheimer's disease when they actually did not. Only 10% after a PET scan were told that they had Alzheimer's disease in this negative amyloid effect. So that is, having access to the results of PET imaging had a substantial impact on the use of Alzheimer's medications. Specifically for patients diagnosed with dementia with a positive amyloid PET scan, the use of Alzheimer's drugs increased from 63% without a PET to 91% with a PET scan. So again, we're really trying to get CMS to pay for this because we believe that this evidence is rock solid. I don't know what the p-value is. Maybe somebody here can tell me, do the math for me, but it's pretty incredible. So the problem with the IDEAS study is that it was primarily in a white cohort. And what we really want to know now is, will this also work in an ethno-racially diverse cohort? So we're recruiting a diverse cohort of 7,000 participants. 50% or more will be Black or African American. And we're recruiting for this right now and definitely reaching out and trying to get this done. Like I said, there's a lot of progress toward a blood test. In fact, it's a global race to see who's going to be first, right? And more research validating amyloid beta and tau in the blood by comparing it to imaging and cognitive testing. There's new research on blood tests for alpha-synuclein and neurofilament light and other markers. In last year at the AAIC, was the first time a rigorous plasma p-tau data were presented in the context of a clinical trial, linking a treatment effective to the reduction of amyloid in the brain and cognitive decline. And the AAIC, that's the Alzheimer's Association International Conference for 2022, is coming up at the end of July. And I actually get to go this year. I'm very excited about that. And I'm really looking forward to hearing more information on this. This says it's not ready for broad use in the clinic, but they're making remarkable progress. I wouldn't be surprised in 3 to 5 years if we've got a blood test. So how are we making progress towards risk reduction and more effective treatments? Let's go way back to 1906. This handsome fella over here on the far left is a gentleman named Dr. Alois Alzheimer. In 1906, he made the first description of the disease. He worked with a patient named Auguste. Auguste died from the disease that Dr. Alzheimer described. After her death, he was able to look at her brain and describe the plaques and tangles that we still know are the pathophysiology of Alzheimer's disease today. It took 90 years for the first drug for Alzheimer's disease, a drug called donepezil, also known as Aricept. All of these drugs, donepezil, rivastigmine, galantamine, memantine, and then Namzaric, which is just memantine plus donepezil. All these do is treat the symptoms of Alzheimer's disease. We know that there are fewer neurons because of the neuron death, and that there's a trouble getting the signals across the synapses because of those beta amyloid plaques. So what all of these drugs do is simply increase the number of signals that are going across the remaining synapses, the healthy synapses that remain. None of them, though, do anything about getting rid of tau. None of them address neuroinflammation, and none of them address beta amyloid. So last year, the FDA-approved aducanumab, or Aduhelm, and this is a drug that has been shown to reduce the amount of amyloid in the brain. What is unclear and is still ongoing in studies is if and how much reducing the amyloid has an impact on the cognitive scores that people taking amyloid get. So stay tuned, but that's our first. We're at bat, and we've got a guy on first, I guess. We've got our first at bat. We got a guy on first here, and we've got to get the bases loaded before we get our home run and really have a treatment to have an impact on Alzheimer's disease and dementia. So it's important to think about the therapeutic discovery pipeline and how the pharmaceutical companies come at this work. So preclinical can take years to decades of work, and that includes laboratory experiments and cellular and animal models, primarily with mice. So you'll hear a lot of stuff about mice. Oh, these were genetically engineered mice. They were genetically engineered to have Alzheimer's disease. That is still way, way, way early in the pipeline. Finally, after a lot of work, they get to the point where they can test human volunteers and look at risks and side effects. So these phase 1 trials will have a very, very limited number of human volunteers. It's not unusual to hear numbers of 20 or fewer people in a phase 1 trial. By the time you've looked at the risks and side effects, and in phase 2, you're going to test more volunteers and get more information about the safety and what might be the correct dosage. And then finally, you get to phase 3, which can take years to decades. And phase 3 trials are often 2 trials with a similar study design, but perhaps different dosages. And then they test even more volunteers. And this is what provides the chief evidence for FDA approval or denial. Today, there are over 100 unique therapies in trials that target multiple aspects of Alzheimer's biology. So in addition, we've talked a lot about amyloid beta and tau. It's also looking at neuroinflammation. It's looking at oxidative stress. It's looking at proteins and cell communication, all these things. Please do not ask me in the Q&A, what is epigenetic regulation, because I do not know. But the scientists know, and they're looking at that as well. And when I am able to talk to scientists, they often tell me that the treatment or the cure for Alzheimer's disease will likely be a cocktail. So you might get something that works on neuroinflammation, something that works, gets rid of amyloid, something that addresses tau, and something that addresses vascular stress or oxidative stress. So it might be a collection of therapies that address these issues. There's also a really big focus on risk reduction, and up to 40% of dementia cases could be prevented or delayed by targeting modifiable risk factors. And research suggests that combining multiple healthy factors may be the most impactful. So you can see our lovely lady in pink here doing a tree pose, showing us that physical activity is important. A healthy diet, a lot of studies recommend the Mediterranean or the MIND diet. And then cognitive and social stimulation are all important. So the Sprint Mind study was the first study to demonstrate a reduction of new cases of cognitive impairment. And what it looked at was blood pressure. So this is your cardiovascular health again. So the study is so important because it suggests that you may reduce your risk of MCI and dementia by addressing cardiovascular disease risk factors. It looked at 9,000 people all over age 50 with all-cause dementia risk. And it compared standard blood pressure management to intensive blood pressure management. The intensive treatment kept the systolic blood pressure at 120 or below. Standard care was 140 millimeters of mercury or below. And by bringing that systolic number from 140 to 120, it reduced the risk for MCI by 19%. It reduced the risk for dementia by 17%, and it reduced the combined risk for MCI and dementia by 15%. Really just incredible. The Alzheimer's Association and the NIH funded a follow-up, Sprint Mind 2.0, to clarify the impact on dementia risk. But right away, we can take away from this that managing your cardiovascular health is just something we need to do. There is also the United States study to protect brain health. It's called the US Pointer study. This is a 2-year multi-center study where they're recruiting 2,000 participants. As you can see over here on the map, we're very lucky in New England. One of the sites is in Providence, Rhode Island at Butler Hospital with Dr. Steve Salloway. They are dividing it into self-guided and structured intervention groups and looking to see if a self-guided group, if there's a benefit in having somebody tell you have to go work out and eat well and have kind of a health coach, or if just doing it in self-guided will work. So far, there are over 1,500 people recruited, including over 27% from underrepresented populations. And this study will really lead the way in the development of an accessible and sustainable community-based program for prevention. US Pointer is not alone, and in fact, it all started up here in Finland with the Finnish geriatric study. It was the first one. But now it's a worldwide study, as you can see, and really where everybody is looking at the aging population and what we can do about Alzheimer's disease and dementia. Every study helps scientists learn more about the disease that they're trying to address. And there's an urgent need for inclusion of individuals from underrepresented backgrounds in clinical trials so that the new discoveries can benefit everyone. So here's one takeaway, how to get involved in research. You can tell your patients, you can tell your family members, your neighbors. We have Trial Match. The Alzheimer's Association cringes every time I say it, but Trial Match is kind of like a dating service for clinical trials on neuroscience. It is at no cost, and it really individualizes which trials you might be eligible for and which ones are right for you in your area. There are over 370,000 users, and we represent over 700 clinical studies at locations around the world. And some of them can be done virtually. You can sometimes fill out a form to participate. So we all remember Dr. Fauci during COVID talking about flattening the curve. And it's no different with Alzheimer's disease. We really want to change the trajectory, and flatten that curve. So in the future, treatment will likely include, as I said, a powerful combination of effective medicines as well as risk reduction strategies. But if by 2025, right, just 3 years from now, if we develop a treatment that delays the onset of Alzheimer's by 5 years, that means by 2050, 5.7 million people who would be expected to develop Alzheimer's in the US would not. So that's pretty profound right there. Here's something else that you can do. You can download our Science Hub app, and it will give you the latest and greatest in Alzheimer's and neuroscience research developments. A lot of the info does come from the Alzheimer's Association, but there's a part here that's in the news, and that's just the feed from your basic news outlets like Reuters, the AP, the major journals, the Lancet, New England Journal of Medicine, et cetera. So some of it is definitely from the Alzheimer's Association, but not all of it. So I hope that you've learned. I'd like to leave you with these resources. Our website is alz.org. You can find out about information at our research tab, download the Science Hub, join a clinical trial at Trial Match, and please, please, please use our 800 number. We have a 24/7 helpline. It's answered live by a live trained staff person 24 hours a day, 7 days a week. It is for patients and their family caregivers, but it's also for providers and clinicians. Ask a question. There are no dumb questions, right? There are only dumb answers, as I'll be proving in a minute, I think, when we get to the Q&A. But 800-272-3900 is the 800 number. So I hope that I showed you that there is hope in research, and I'm happy to now stop sharing my screen. And if there were questions, I'm happy to take them. Thank you, everyone.
Liz, the first question we had is from Teresa. She said, does every patient advance at a different pace? Her mother-in-law is still mild after being diagnosed in 2021.
Yeah, absolutely, Teresa. The rate of disease progression will definitely vary from person to person. And I know that there's research ongoing into that. Some people will only live for a few years after the diagnosis, while others will live for as long as 20 years. And I don't know that we have a good explanation for that yet, but that is absolutely true. And thanks for sharing best with your mother-in-law. I'm sorry to hear that.
The next question is from Joan. She said, you mentioned HRT as an impact on Alzheimer's dementia. Can you expand on that?
HRT. Trying to, let me look at the, Joan, I'm not, can you type your question again? HRT, I'm not sure what I said, and I'm sorry, but I don't understand the question.
While she's redoing her question, Tammy asked, how do you get patients into studies when they're resistant to having any treatment or don't have an awareness there are cognitive issues?
Yeah, that's, so the resistance to acknowledging the disease can be a behavior that's part of the disease, right? So that would be definitely a challenge. And just sometimes that may not be right. That may not be the right thing for them. If the person is still in denial about having the disease, then it's unlikely that a clinical trial will be appropriate for them at that particular time. And you may just want to continue to try and advocate, but there's, clearly not a lot you can do in that case. I'm really sorry to say.
Joan's question was about hormone replacement therapy.
Oh, sorry, Joan. HRT, of course. Sorry about that. So I cannot expand on it right now. I'm hoping that at the AAIC coming up at the end of July, that we'll have more on it. But I guess that overall, what is it about women's health that makes women significantly, exponentially more likely than men to have the disease, right? So is HRT neuroprotective, or is it neuroharmful? We don't know. What is the age at which you would initiate it and have an impact or not? Those are all the things we're trying to tease out and identify. And to date, I don't have any endpoints that I can give you.
Cheryl asks, what do you think about recent research that says older folks who nap are at a higher risk of Alzheimer's?
So that gets to the sleeping, right? And healthy sleeping and your overall healthy lifestyle. So if you are getting more than 7 to 9 hours of sleep, and especially if that sleep is fragmented. So let's say that you're napping for 3 hours and then going to bed and sleeping for 6 hours and then maybe taking another nap for 2 hours. That indicates that there's something going on with your clock, right? And that is why there may be a preponderance of Alzheimer's disease in people who are having frequent naps.
There is a question that was on the chat. Are more PCPs doing screenings? Sometimes it takes an awful long time to get a neuro appointment and to help define and suggest treatment.
Yeah, so primary care is thank you for that question. Primary care is absolutely where it's at. And primary care does a really good job of screening. What we find is that primary care physicians have a concern, though, about making the diagnosis, although it's been shown that they're very capable of, they being primary care providers, are very capable of making the diagnosis in the primary care setting. But there's a lack of support. So that is, if I'm a primary care provider and I make the diagnosis, one of the big questions is, okay, I'm pretty sure you have Alzheimer's disease, but now what am I going to give you, right? What am I going to do? So that's a lot of what we're doing with our education and training. Here are the currently available therapies, the donepezil, and emamantine. Here is the Alzheimer's Association. You can get the person in touch. You can get the person in touch so they can do long-term care planning, give them some hope if they want to register for a clinical trial. So those are all the things that we're working with primary care practices on.
Is the Alzheimer's Association connected with acute medical centers to enroll patients in the Pointer studies?
So the recruitment for the studies falls to the academic medical centers and the primary investigators. So it's Butler Hospital, Wake Forest, one of the University of California, places that I'm not going to remember. So they're the ones that are really doing the recruitment. Certainly we're helping with that, and we're helping them by employing navigators that will help with the management of the study. But as far as recruitment for the study, that's pretty much up to the academic medical centers. So that would be a question for Dr. Salloway at Butler Hospital, if you have an idea.
Ramona asks, what countries have the highest prevalence of dementia, Alzheimer's disease?
That's a great question. So we don't really know because not all countries are as forthcoming with their public health data as others. So we would anticipate, for example, that China would have a very high prevalence of Alzheimer's disease and dementia. We know that their prevalence is that they tell us is right around that of what it is in the US. But because of the level of smoking, lack of access to healthcare, et cetera, we would anticipate it would be higher, but we just don't know.
It seems like an anonymous question. It seems like doctors are only using Aricept and not many of the other drugs. Any comments or reasons that that might be happening?
That's also a good question. I'm not a provider, so I don't, I'm conjecturing here, but it certainly is the one that's been out the longest. So it has the longest track record. I know rivastigmine is typically a patch. And also donepezil is the only one that is approved for use in all stages, mild, moderate, or severe Alzheimer's disease. So that's probably the big reason.
What do you feel is the best screening tool at the PCP level? Is it the Montreal Cognitive Assessment, or is there something better?
Yeah, so the Alzheimer's Association is not prescriptive about which tool. People have the one that's working for them. I will say that the MoCA, the Montreal Cognitive Assessment, changed last year, and now there's a fee to use it. But if there are many validated instruments out there, and so the one that works best within your practice is the one to use. There's the mini mental status exam. There's the 88, and if you go to the Alzheimer's Association website, alz.org, and at the top, click professionals, and I'll try to put this into the chat, that it will give you guidance on several of the available screening tools and how to use them.
Well, thank you, Liz. I think that's it as far as question. Just thank yous for coming in.
Oh, thank you, everybody.